Hi, everyone. Thanks so much for joining us for this latest episode of Medically Speaking. I'm your host, Heather Lee, and I'm here today with Dr. Chelsey McCabe, who is the Director of Behavioral Health and also a psychologist at Oishei Children's Hospital. Thanks for being here.
Yeah, thanks for inviting me. I'm excited.
Yeah, we're excited to have you. And when we talk about mental and behavioral health, I feel like there's been a lot of conversation about it, as there should be. First, let's talk about what falls under the umbrella, because I feel like we hear those terms a lot, but people don't really understand what mental and behavioral health actually is.
Yeah, that's a great question. And I think, too, the field has also expanded to have it be more behavioral health than just mental health, in the sense of it is a whole spectrum of you can have, a specific disorder as far as anxiety, depression, attention deficits, bipolar, schizophrenia, versus also your behavioral, what you're doing in your day-to-day life. Maybe you don't meet diagnostic criteria for a specific disorder, but you are struggling and it's good to get help. And again, those can be adjustment disorders or a stress-related disorder.
One of the things that I had learned about is somebody had mentioned autism, and I never really thought of it under that umbrella. But when you really think about all of the moving parts and the treatment and the specialists, it makes sense.
Yes. And again, with the different developmental disorders, again, technically ADHD, it falls under the same umbrella as the autism. So it's really coming together. And thankfully at Kaleida, we have, specific the Children's Psychiatry Clinic, but we also have Robert Werner Center, and the staff go between. I actually have a meeting later today with Dr. Michelle Hartley-Andrews, who's the medical director of that clinic. So we really do try and collaborate and make sure we're giving care across the system.
And I think that's what's so special about having, the intensive outpatient program, the Children's Psychiatry Clinic in Oishei, everybody working together, because you can really have that continuum of care from inpatient to outpatient, making sure that you cover all of your bases.
Exactly. So we're not only, again, at the outpatient center and collaborating with some of the other centers, but we are inpatient as well. So a lot of times, too, when someone's inpatient, if they need follow-up care, the team that is in the hospital then can coordinate with our team that's outpatient. And then we are also in some of the other Kaleida clinics like Niagara Pediatrics and Broadway Pediatrics and Healthy Way. So we also have, some presence in those clinics, which makes it helpful to be able to just coordinate care.
How does it make it better for patients when you have that continuum?
Yeah, I think the best part is honestly the warm handoff, in the sense of, when you are at one of your appointments, you can then have the information. We actually do too try to partner with the community too, so that if I have to, make a referral to somewhere else, that I know those things. Because when you can say, hey, this is where you're going to park, or this is with the hours that they're open, and that information, people are, again, whether it's mental health or even other types of appointments, you then feel more support. You're not just going in being like, what am I looking for? And so being able to just have more information and know the different systems helps then get the care you need.
I feel like it also helps to remove some of those barriers to care, right? The easier we make it for people to get the care they need, it could be something as simple as transportation or parking. Yep. You remove those layers. Yep. Get them to where they need to be, they get the care that they need a lot quicker, and they feel more comfortable.
Right.
What about who utilizes the services? I think about the 12th floor at Oishei, for example, our hematology oncology patients. How might the patients and their families connect with your team, and how do they help?
Yeah. So again, there's a wide spectrum of services that are available. So there is actually a psychologist on the 12th floor who's full-time, who works there, and the team member or a family member may meet with that team and have support while they're actually on the floor. And then again, there is Roswell does have an outpatient psychology center too, and an outpatient psychologist. So they may meet with that psychologist, or two, sometimes they connected with someone that was from specifically Oishei, and they can come to us. We do a really nice job of, when we get a referral for a patient that's seen at Roswell, connecting with our partners at Roswell to make sure, hey, what are the services that they're already getting, just so that we don't overstep, and we make sure that we're providing, again, the care without the patient having to do that extra work.
Because there's a lot that goes with the physical diagnosis. Mm-hmm. How do you cope with that? How does the family cope with that? That people don't always think about. Yes. They think that you get a cancer diagnosis and it's strictly the medicine, but there's the other part of the treatment as well. And how important is it for family members to identify that a child needs some intervention, and how the quicker the intervention, how that can make a bigger difference in their care and their outcome?
Yeah. So again, kind of one of the reasons why I went into child psychology, because you can kind of specialize with, geriatric or adult or, even different populations. And I think one of the most amazing parts of being able to help kids when they're younger, they really can change these trajectories. You can change, the physiological responses that you have to stress, things like that. And so being able to, intervene, even when there is a baby, or we have some like nurture and play groups, which are for moms with infants, just to be able to support moms in their role of supporting their child's development. And so the earlier you can intervene with that, the better, as far as then those are the neural pathways that get developed and being able to help, prevent long-term mental illness.
And it's that positive domino effect, right?
Mm-hmm.
And starting earlier. I've heard some people say mental behavioral health in kids can't possibly be dealing with, some sort of mental illness. It couldn't be farther from the truth, especially when you look at some of the surveys, a recent survey of high school students. It was nearly half of all high school students surveyed said that they struggled in some capacity at some level with mental and behavioral health issues. That's astounding.
Yeah. And again, I think that this is the hard part too, because we don't want to pathologize or say every single thing is, negative, or that if people are saying that they are struggling, that then means, you have, again, you meet that diagnosis, or you have depression, or you have anxiety. But again, that's why there is still help, though, when you're struggling, and how you respond to that. And I actually think this is like a unique part of the mental and behavioral health field, that one, it's being talked about more. So people have opportunities to be able to share their experience, or what works or what might not work. So that's a good thing. But then too, again, this being able to intervene younger, in a sense of just being able to, for a long time, the parenting approaches that were taught were very behavioral, right? Mm-hmm. Your child has this happen, and then you have a consequence. And that was kind of where, a lot of the work was being done. And that work is still important at times, but also there's a lot more work now about attachment and nurture, and how we can, provide validation and, shift those consequences, and also just think about like, hey, what was going on before, which was what we call antecedent control, to be able to look at the environment and say, hey, maybe my kid's acting this way because of this, not because of what my response is. And so
preemptively.
Yes. Support. So that helps, again, versus in the actual like parenting world of it, but then also intervening, and how does the community and the schools and all the people actually come together to support this child.
On that note, what should parents look out for, and how do they know what they can tackle at home, and when it's time to seek professional help, and when they should call your team?
Right. That's a great question. And I think, again, one, the pediatricians are great resources in the sense of you're seeing them, regularly and more often. And so sometimes a pediatrician can be just a good person to talk to. And a lot of the pediatricians also have some mental and behavioral health support in the offices now. So that's just like a nice person to check in with. And we have really good relationships. And so do other agencies in the community to be a referral source for that. But also being able to just kind of know your kid's baseline. So if your kid was always a kid that was very social and wanted to do lots of things, and that changes, that's a really good indicator that like something's different here, right? Or they were a really social or talkative kid to you, and they would be out of their room and be willing to kind of engage with you, and that shifts. Versus like if you did have a kid that really did prefer more alone time, and they always have had only maybe one or two friends that they like to connect to, and they're not
out of the ordinary.
that then that behavior wouldn't be something that would be atypical for their kid, but maybe for another kid would. And then there are just like developmental differences, right? So we know that like parents are actually really important and really, really, liked by kids when they are in elementary school. That starts to shift a little bit in middle school. And by the end of middle school, you really do see the shift of like some attitude changes. You have hormones. And so also knowing there too, like you don't want to come down too hard and be like, you need therapy now, right? But you want to be able to get a sense, are they still engaging in their hobbies? When they're around their friends, do you still see that irritability, or is that gone, right? And being able to really just be mindful of the whole picture, and not just, okay, they're angry at me only.
I think about my mom, you're just being a bratty teenager, So, but I think the baseline and knowing what that baseline is can really help you sort of navigate. mental health needs have increased, obviously, especially over the past 2 decades.
Mm-hmm.
We've seen a huge increase in the patients we serve, the people who are calling. How has OSHI changed its approach? What are we doing to better serve the needs of the community?
Yeah, I think that's the most exciting part about my job is OSHI and Kaleida is very dedicated to mental and behavioral health. We had the Festival of Trees in honor of the behavioral health at OSHI this past December, which was a beautiful event, and just being able to grow the services because of the fact that the need is there. Our clinic has grown tremendously. We went from 8,000 to 9,000 visits in a year to about 13,000 visits in a year. We've hired more teams. We've also grown. We now have an eating disorder intensive outpatient program, which is 3 days a week, 3 hours a day, and being able to get intensive services for eating disorder right locally for, age 8 up until 18, whereas before there was some older adolescent services, but nothing younger. So that before you had to go to Rochester or even sometimes out of state and things like that for services. So to be able to keep it here in the community and grow these different programs has been
And I've spoken with
great.
Families who previously had to travel out of the area and luckily, were able to come back at the very start of that program. What difference does that make for these patients and really for the families? Logistically, being closer to home is easier. Being able to go for a couple of hours versus taking a ton of time off of work.
Yep.
But in their recovery, how does that help being closer to home?
So if you think about so eating disorders, unfortunately, is one of the harder disorders to treat in the sense of, when someone's struggling with depression and say we make some recommendations and you go and try these things, you actually feel better pretty quickly. And so then you're like, I like my therapist. I want to do this work. And you get some relief and it's rewarding. Yeah. Whereas an eating disorder, unfortunately, some of the times when I say, hey, I need you to eat all of these things that maybe you weren't eating before or you had stopped eating, you can actually get pretty mad at your therapist because it doesn't feel better. You actually feel worse maybe in the moment of that first initial weeks of recovery. And so what can happen if you go away for the treatment and, the family can't go and it's a residential, you come home and what happens is that then sometimes those symptoms can start again because, again, what you're then kind of in when you're at the residential, it was protected and you were able to kind of do some of this work. But then once you're in your home environment, it's harder.
It's getting back to the real world.
The stress is there again. So the nice part is, one, we do it from 3 to 6 p.m. So it's after school. So you don't have to get pulled from your school day. There's parent components. There's a meal that we do every day. So all of that stuff, you're kind of putting those skills into place and we're checking in, hey, this is what we were doing on, because it runs Tuesday, Wednesday, Thursday. How did Friday to Monday go? And really can have an open conversation and provide that like in vitro support of, this is, we're going to make this happen.
I think one of the interesting things in talking with some patients who have seen you and your team for various diagnoses, the overarching theme was there is no quick fix. There is no, definitive finish line, so to speak. One patient described it to me as a roller coaster, and you're kind of always on this roller coaster. You're going to have highs and you're going to have lows. But this particular patient described it as having tools in their toolbox. It's not always a prescription. It's sometimes giving them the tools they need when these tough situations arise or these difficult moments arise, that they know they can tap into that toolbox and they know how to tackle it better than they ever did before.
Yes, exactly. And again, there isn't like a one size fits all. I even tell patients right when they come in, I try and do this on the assessment appointment because again, you're coming in, you're meeting with a stranger, you're giving all of this information. And so I try in our team really does a really nice job of even just in that first initial appointment that we give you some tools already and some psychoed just to walk away from that first appointment that I want to come back. But I say it's not like a headache where I can say, here, take this and your headache is going to go away. And then, you're going to feel better tomorrow. This is a lot of work. Again, some things I suggest might not work. And I want you to be as honest with me like, hey, that didn't go well. Please, let's try something else. And something might fit really well. And so trying to also establish that relationship with your therapist or, if you're seeing a psychiatrist, just be one, really open and honest. And then two, knowing that like when something doesn't work, trying to not become too discouraged that there's other methods and there's other things available.
There's that level of trust that they're building. And that doesn't happen overnight.
Yes.
Sometimes that takes some time as well. What about the other teams? You had talked about, working with schools and other organizations to make sure that patients get the care they need when they need it, where they need it. Talk about the collaborations that we have in place as well.
Yeah. So Buffalo has, a good community of mental health agencies and providers, and being able to collaborate. We are fortunate enough to even have a grant funded collaboration with the Mental Health Advocates of Western New York, who have been a great partner in being able to, offer peer advocates, which are people, or family advocates that are people that have had personal experiences with these diagnoses in these systems to get support, as well as then being able to offer respite to families that need it. They have the teen chat line, the suicide teen chat line that they run. So within that, we partner with them all the time, but also we, have lots of partnerships with the different agencies. Horizon has a full package DBT program, and they also have a lot of maternity services. So we make referrals to them, and they make referrals back to us to our eating disorder. Same with Best Self, Child and Family, Endeavor. There's a lot of us, and Spectrum Cares are where we really are in communication. There's an Erie County Suicide Coalition that OSHI is a part of, that we are on that monthly meeting and kind of get updates. Erie County, is similarly like OSHI, really trying to meet the needs of mental and behavioral health. And they even have a monthly meeting that leaders attend, that I attend, that again is kind of checking in with these different areas of need.
It takes a village. We mentioned the IOP, the intensive outpatient program. What inpatient services are there at OSHI? Who might go to OSHI for, a stay of a varied length? For what diagnoses?
Yeah. So again, kind of this is where OSHI, I feel like, has grown significantly, and even in the last 2 years for mental and behavioral health at OSHI, and that now there are 2 full-time psychologists that are inpatient that are there to support, in addition to the psychologist that is on the 12th floor, which is the HEMOC floor. But now there is a psychologist for the other floors. So again, you might be at OSHI for a trauma, and you're really struggling with the kind of thoughts that have happened over the past few days, or if there was grief related to that. So our team would check in for that. You might be struggling with diabetes, and, a lot of times you think, okay, that's a medical disorder that is, not kind of covered by mental and behavioral health.
But the feelings that go along with that diagnosis.
And even too, just the care that it takes to be able to check your blood sugars, to make sure that you are, if you're on an insulin pump, that your pump is ready to go and working, and the behavioral strategies that actually support, hey, maybe it even is just, you're taking a pill, having a pill box for reminders. So a lot of these different components of the medical disorders we can support by being able to just help with, one, being a child managing this, and how does the parent manage that conflict when the child doesn't want to, but also just being able to support the actual stress of the illness. So that happens. And then, unfortunately too, at OSHI, we see people who have had suicide attempts, and someone who's really struggling and in the midst of a crisis. And then our team will evaluate and kind of come in and be able to offer support and kind of link to what you need. So
that might be an inpatient stay.
Yes, that might be an inpatient stay.
I think about something that I know a lot of people that have had, a baby in the NICU. Some are for a couple of days, some are for a couple of months. That is a challenge that a new mom or a new parent, where a psychologist would come in and work. And that's something that's relatively new to OSHI, where you saw a need and decided to expand on that program.
Yes, we're very fortunate. The Senslick family made a donation to be able to support the role of a psychologist in the NICU. That was very recent, within the last 6 months. And again, this is where too, I think our team is very talented, and we've been really fortunate in the sense that we then reached out to the Children's Hospital of Philadelphia and Milwaukee Children's Hospital to be able to have actually one of the NICU psychologists came from CHOP to do an intensive training with us to say, hey, this is how things work in our NICU. This is how you can have a psychologist in this role, to make sure that we're following the standard of care and being able to support the moms the best that we can. And so, that program initially got started at the beginning of the year, and the psychologist that's in there is seeing many moms a day, and it's making a bit difference. And one of the moms even recently said to her, it was right when she had started, and it was at the end of her stay of the NICU, she was like, oh my gosh, this was just the support that I needed that I didn't know was missing. And so to be able to have that now and offer that, I think is a really important thing.
And you mentioned a grant. We talked about Festival of Trees, the importance of philanthropy when it comes to a lot of the mental and behavioral health programs, because I think there's the misconception that a lot of these services are covered by insurance, which in many cases couldn't be further from the truth.
Yes. So unfortunately, right now, the way that the inpatient services at Oishei work, because we are a medical hospital, the psychologist times is not reimbursable. So that's when they're in the NICU, when you see the psychologist in the ED or any of the floors, or even the psychologist that's on the 12th floor for the cancer and blood disorders, that time is not covered as all philanthropy. So we are very fortunate that people in the community have stepped up and are willing to support these because there is a need. And then even on the outpatient level, so our intensive outpatient programs, some of the insurances cover them and some of them don't, or that they will cover at a very, very small rate for, if you think about an intensive outpatient program, we have a dietitian in that program, we have a psychiatrist, we have a psychologist, we have social workers, we have a massive team that's kind of supporting these families and being able to, and the reimbursement rates unfortunately don't always match the amount of team members that are needed, and we're really intentional about making sure people get the care they need.
Yeah, we don't want to do less. We don't want to have fewer people, and we certainly don't want to turn anybody away.
Right.
Let's talk stigma. I love that we're having this conversation.
Yeah.
I love that people are going to be listening to this and maybe hopefully learn something that you didn't know before. There are still both the internal and external stigmas when it comes to mental and behavioral health. Let's talk internal first. People don't always want to admit that they're struggling. How do you tackle that? How do you make people feel that it is okay? It's okay to not be okay, and it's okay to ask for help and to need help and to want help.
Yeah, I think that's probably one of the more important messages that we can talk about and be able to, one, that just the same way if you got diagnosed with, cancer, that you're not saying what did I do wrong or how come this is happening to me, to do the same with our mental and behavioral health. Similarly with someone who is struggling with suicide, that this is not, their fault, quote unquote, or that they, did something that led them to this, and trying to take away that internal blame. There's a study that I always reference when a patient struggling in therapy that was done among college students of a professor that came into class and gave a pop exam. And they surveyed people's anxiety, and they surveyed people's reasons for, failing this pop exam, this pop-up, or whatever you would call a surprise exam. So what this results showed of this study, that people that scored higher with anxiety, the reasons why they said they failed that exam was that they didn't study enough, that they were, their own personal struggles. They blamed it all mostly on themselves. Versus people that had lower scores of anxiety wrote stuff about the professor, about the class, about it being unfair. Notice that these were even going to happen. And so I try and use that study as a good reference of even just thinking about that for your own disorder, right? That unfortunately, the disorders sometimes can inherently make us feel like, what did I do wrong? So then you don't get help, or so maybe you're not motivated in treatment because of the fact that you have all of this shame around it, versus if we can externalize it, hey, this is just the same as if your body, right, had high blood pressure and you have that genetic history of it.
What do?
And
you treat it.
Yeah.
So let's treat it the same way. The external stigmas and how other people view mental illness or mental and behavioral health issues, sometimes that's a little bit, because I can't control how you feel about me and vice versa. Again, conversations, I think, are the start of it, right? Getting people talking about it and hopefully helping to make people so they don't feel embarrassed or they don't feel shame. But how do we tackle some of that? Because we're talking about it, but I feel like we're not talking about it enough.
Yeah. And I think, again, this is where there's probably is more growth to be done. I know Dr. Turkovich, when he speaks about this, he has shared how he's had second grade teachers that he had reach out to him on Facebook to say, I have so-and-so, can you help connect me? Or, being able to just, if you yourself struggle, or if you have a child who struggles, being able to share the help that you get and how to normalize that most people are impacted by mental and behavioral health at some point in their life, that that is a good thing to talk about and share, and just how we use that language and express it. Even the media has done a really nice job of no longer saying committed suicide. People say die by suicide now. And again, that's a really important difference, and something that like we talked about in our clinic, of even just like also how asking people how they want to say, what they're struggling with. Like you are a person with anxiety versus like the anxious kid. And some people are okay with different terminology, but opening those conversations up to the words that we're using and being really mindful of how do we share these experiences so that people feel okay talking about it.
What about the people that see coming forward or seeking help as a sign of weakness? How do we tackle that?
Yeah, I think, again, one of the most ways is showing the strength, like, right, even the Festival of Trees. It's interesting. I don't think, and, I don't want to ever speak negatively of something, but I don't think a few years ago we were in a place to show those stories of those patients. Like, it was really hard for one, even on our team, to find patients that wanted to talk about it.
Because it's very personal. It's very private.
And I know, too, there was discussions about not making it so that someone then shames that person's week. But I think the stories speak for themselves. And when we're able to share kind of, this was my experience and this is, how I improved and these are the things that I still need to do, I think it really does break that. Like, you wouldn't watch any of those stories and say that person is weak.
No, but not by any means. When they pick up the phone, the help is needed now. We are making strides to expand our program, to expand the spaces. But I think that's a powerful statement right there, because a parent is not calling right now for something that might happen 6 months down the line. They're many times desperate to get their child help right now. How can we better help them, and what are we doing to make sure that maybe the wait times are that much shorter and we can hire that many more people and therefore help that many more patients?
Yeah, I think Dr. Marshall speaks of this a lot too, of this being able to, our goal is that if someone calls us and says, I want help right now, that we can help them right now. That is a very big goal, and something that, a few years ago, our wait list really was 6 months to a year, and we've brought that down. Sometimes we can get someone in as soon as, a few weeks, and sometimes it does still hit that 3 months. We're able to never have anyone wait more than 3 months, but even still, when you are struggling, you still don't even want to wait 3 months. So we thankfully, again, with philanthropy and with other initiatives that Kaleida has, we are going to grow into a bigger space in the new year in 2026. And so being able to grow physically, to hire more people. Also, there's something called the partial hospitalization program. So I've talked about these IOPs, which are 3 days a week, 3 hours a day. The partial hospitalization programs are 5 days a week. They can be anywhere from 5 to 7 hours a day. So being able to open one of those, that's our goal too. So that,
who would utilize that?
So that would be, so a lot of times it's either like if you're really struggling, and again, maybe you're having suicidal ideation, or you haven't been to school, or you're not, functioning in the way that you used to be. It could be that before you go to an inpatient hospitalization. So right now we have Bryland and ECMC where someone would be hospitalized inpatient if they were, at the point of crises. And those, can be 1 to 2 week to 3 week stays depending on the need, and so the goal is for the partial one to maybe even prevent some of that, but also it can be for someone who's inpatient and maybe not ready to just go back to, once a week outpatient counseling, or, the getting back into school is going to be a challenge.
Sort of the bridge
between an inpatient. So we use the word step down from the higher level of care, or sometimes if you're just weekly outpatient, we call it a step up into this higher level before you need to actually get to the hospitalization.
One of the numbers that was pretty staggering, the Surgeon General talked about the number 11. That is the number of years from the first mental health symptoms that a child experiences to the first time they get treatment. Yes. 11 years. We talked about 3 months being a long wait, but 11 years. What takes so long? Is it because parents maybe don't realize that something is actually an issue? Are kids really good at hiding the things that are bothering them? 11 just seems quite frankly, unacceptable, right?
Yeah. I think, again, both the reasons that you just mentioned, and two, sometimes it's just the ability to be able to find the resources, get the, again, sometimes too, we do have an intensive outpatient program for obsessive compulsive disorder too. And that treatment for that disorder, you need to be highly trained in a specific treatment modality to be able to. So sometimes too, maybe even someone was receiving treatment, but they weren't getting that specific treatment that they needed for that disorder. And so, that sometimes happens where someone came to us and they have had 3 different therapists before and it didn't get better. And, those are the really heartbreaking. We had a family call recently that they actually got referred to treatment out of state because they didn't know that our eating disorder program was in Buffalo and happening. And the mom said once she found us, but it had been months. And again, we're doing a lot of things like this podcast. We're trying to talk with pediatricians, but
there's still people that don't know.
Yeah. And then even too, so we also now have, this is funded by the Office of Mental Health, a suicide prevention grant, where we have a psychologist or a clinical social worker in our emergency department that all the patients who come into the ED at Oshai and actually in the other facilities in Kaleida system, if they're 11 or older, they get screened for suicide. And so now,
which is a very real thing. People hear 11 years old, you're still young, you can't possibly... It is very real.
Yes.
It is happening in our community.
Yeah. And we've partnered really with the triage nurses. They give this measure and they are, supporting. And then again, it can be a warm handoff to one of our team members in the emergency room. And we've gotten so many feedback from the nurses, registration actually, and then the parents too, to be like, we were coming here because of, they needed stitches or something, but they asked that question and then getting to talk. I had no idea that my child, was having that. And I do think the community too, I know even at my own primary care, I get asked some questions about anxiety. But again, I think some of the hard part about that is then making sure the right follow-up is in place. So when you have a team member there that can then give that feedback and, hey, this is what you do, that then helps and hopefully will help catch some of those people that were previously waiting 11 years.
Social media. It's good. It's bad. I love it. I hate it. I'll admit there are certain things that I will see on social media that make you feel great about yourselves. There are other things that you see and it makes you feel terribly, whether it's the way you look or maybe you're not quite as successful as somebody. We compare ourselves a lot. And I think, Instagram and Facebook and all of the things, they make it easier to compare. How does that play into sometimes the struggles that maybe young people are facing these days? Because when we were younger, we didn't have, your life wasn't on display. It wasn't this picture perfect thing for everybody to see. Yeah. Does that play into some of the struggles?
Definitely. And I think this is actually a hard one too for parents because, right, sometimes we just want to say no social media then or no Snapchat or kind of just not give that to their child, which I respect. That's we talk with parents all the time about this, but the hard part about that is that then if that's the way other kids are connecting and you don't have access to that,
it's another can of worms.
Then your child kind of gets held back from that, right? And so there actually again has been a ton of research on this, and it's kind of like a bell curve in the sense of like how much you should have. So if you have too little, if this is on you're thinking of like how people are doing mentally with it. If you have too little, you actually can be struggling. You can be on the lower side because you don't have that connection, right? And then you go up and you have a certain amount that's good. It helps with social connection. It helps with making plans. It helps with staying connected. But then if on that other end, if you have too much of it, you really then are going back to where this is really hurting your mental and behavioral health. So being able to like just as if we were riding a bike and you're going to say, here's your helmet, here's your knee pads, here's your training wheels, and we're going to help you through it. That's what we want to do with social media, of really supervising. And when we introduce these things, showing the ways to use it rather than just be like, don't use it, right? And then also being able to just support, like just if you fell down, right? And you scraped your thing, you're not going to say never use this again, right? So if a parent their child has an incident where they maybe did something on social media or shared something or saw something, then again, sometimes the reaction is be like, take it away, right?
Yes.
And so we have to be really mindful that this is the culture, this is a part of it now. And how do we, again, have a reaction to something that happened on social media and use it as an opportunity to learn, grow. And again, sometimes it is good to take breaks from it and have those phone free times and modeling that for you as the parent, right? To say, all right, when we are at dinner, I'm not pulling my phone out then either. And it's a really different time. Again, back to like parenting being very different from behavior consequence. This is also a really different time to be a parent. And how do you support using these different devices without, again, shaming or creating more conflict around them?
When it comes to parents who might be listening and they're wondering, okay, I think my child might need some intervention, might need some help, what are the steps that they should take to get the ball rolling, to get their kids the help that they need?
Yeah, so Erie County has the Erie County Path website that shows all of the different like mental and behavioral resources that are in the community. So that's like if you just want to Google, you can then see all of that. Again, the pediatrician, the school counselors, talking to someone like in your immediate can be good. And then again, other parents it's easier and more savvy, tech savvy, and can find, the direct clinics that they need. Or, again, when even if we have a parent call our intake, so we will support, even if it's like, hey, maybe you're not the best fit for us right now, or we do have a wait, but we know this program, we keep in touch, like they can get someone within 5 days. So even just picking up the phone and calling one of these clinics in the area, I know that I trust the community partners, but ourselves too, just to be a resource for these different avenues that are needed for, being able to navigate, what do I do?
Yeah, absolutely. And again, before we wrap up here, a lot of exciting things on the horizon. Again, a new space to help more patients. It's not just a shiny new space. There really is meaning behind it. And it's helping more people, getting more providers, and cutting down that wait time. Mm-hmm. So when, again, should we start to look out?
So that should be hopefully in the new year, around, January, February of 2026. We hope to be in our new space and growing and hiring. And then again, shortly after that, hopefully having a partial hospitalization program as well.
Yeah. That's our big goal, is to have so much more capacity for care. Mm-hmm. Any final parting thoughts before we wrap things up?
I think, you and the Kaleida team and Oshai, I think there's just a lot of support for mental and behavioral health. And I think that that's already breaking the stigma and talking about all of the things that we talked about today to make this mission to be, a better Western New York.
Yeah. It is okay to talk about it. We want you to talk about it. And we appreciate you so much, Dr. McCabe, for being here today. And I can't wait to have you on again when we talk about all of the expansions and all of the new cool things that we're going to be doing in the future. Because we will be doing them, putting that out into the atmosphere. Right?
I love it. Thank you.
Thanks for listening.